Hey there, and welcome to Immune Matters, the podcast sponsored by the PIDTC, where we dive into issues related to immune deficiency and dysregulation. I'm Dr. Jack McDonnell. I'm a pediatric immunologist at Cleveland Clinic.
I'm Dr. Elie Haddad, an immunologist and bone marrow transplant physician scientist at Saint Justine in Montreal, in Canada. That's why you hear the French accent. We both care deeply about rare immune conditions and also the people who live with those rare conditions. And in this podcast, we are very excited to bring you the latest groundbreaking research and insights from the field and from the PIDTC research. Whether you're a provider, a patient, or just curious about the immune system, we are glad you're here and we hope you will enjoy. So now let's get started.
And now we're excited to welcome our two guests, both leading experts in Wiskott Aldrich syndrome. Dr. Davila, thank you so much for joining us today. Could you just start by telling us a little bit about yourself?
Thanks for having me. As you mentioned, my name is Blachy Davila, and I am a bone marrow transplant doc in the Division of Cancer and Immune Deficiency in Cincinnati Children's, where I only focus on patients with immunodeficiency. So both helping diagnose and manage them, and then taking those with severe aspects of the disease that might need a bone marrow transplant to transplant and follow them through and after.
Excellent. And Dr. Alexander, could you please introduce yourself and just tell us all the great stuff you're doing?
Sure. Yeah, thank you so much for having us here today. Very excited to be on this session. My name is Jessie Alexander. I'm an associate professor at Stanford University, where I work in pediatric stem cell transplant. Same field as Dr. Davila, where basically we're caring for patients who have very severe genetic diseases and diseases that benefit from getting a completely new immune system.
Excellent. Well, thank you to both of you for joining us on our inaugural episode. Elie and I are very happy and delighted actually to welcome you to the podcast. And I wanted to start out by getting your thoughts on kind of what is Wiskott Aldrich. And along the way, I may ask you some clarifying questions just because I want to make sure that our audience comes from different backgrounds, that we all are tracking on what this is. But can one of you guys just take us through what this disease is?
I'll let you start, Jessica.
Okay. All right. So Wiskott Aldrich syndrome is an X-linked disease. So it affects boys due to the inheritance. And it is a rare immunodeficiency. And we would also say a problem with immune regulation. So what can happen is this mutation that happens affects primarily the immune cells and the platelets. And what these boys experience then with the immune cells being affected is recurrent infections, as well as just difficulty clearing infections in a time frame that we would expect, and the fact that these infections can be more severe. So instead of having, typical childhood illnesses that clear quickly, these are more severe infections of the skin, sometimes of the bloodstream, and even just very severe ear infections can also happen with these patients. And then they also have small platelets and a low number of platelets. And I think the small platelets is a really classic thing because it really is specific to this disorder. There are a lot of things that cause low platelet counts, but this is really distinct in that the platelets are very small and very wimpy. So that, you could have a patient with something called ITP with a platelet count of 20,000 who wouldn't have as much of a risk of bleeding, whereas a patient with Wiskott Aldrich syndrome has a higher risk because the platelets are very small. So they can present with bleeding. And then again, with the immune dysregulation, they can have autoimmunity, which can affect many things, including the blood, the liver, and other areas of the body. And then also they can be predisposed to malignancy.
So it definitely sounds like a serious thing. So Blachy, like, what do we do about this if we have a patient, who's diagnosed with this condition?
Yeah, this is a good question. I think how we approach the patient at the beginning might change a little bit depending on how the patient is presenting. Because, as Jessie mentioned, this can manifest in a lot of different ways. But not everybody has everything at the same time. You know, some patients may just have the platelet issue, but are otherwise doing okay from the infection standpoint. And some patients might have occasional infections, but that may not be as bad as a problem as the autoimmunity part might be. And so addressing what the most severe manifestations of the disease are is going to be an important part of the initial management of the disease. There are some different treatments that we can do for patients that have bleeding only manifestations, or sometimes for patients that have the severe autoimmunity aspect, there's a lot of manipulation of the immune system that we have to do in order to control that inflammation as best as we can. But ultimately, all of these different medications that we can do are all sort of temporizing measures to control any of these complications. But because the actual cells that are being made in the patient are always going to have this complication, then the patient is going to be at risk of these things continuing to happen for the rest of his life.
So to better translate what you say, in order to be sure, you mean that the only definitive therapy for this disease is bone marrow transplantation or gene therapy, correct?
Correct. Yeah, I think that's where I was headed, is really we, depending on how they present, we can do a lot of different things, but ultimately, because it's going to persist, that's why we always consider stem cell transplant as a possibility.
And I heard also, I know, since I'm the immunologist of the room, so if you say weird things on immunology, I will be there to correct. No, I'm kidding. But speak us about the classification, but I think there is a classification and it has an impact on how you take care of the patients, correct?
Yeah. So I think that goes back to the history of Wiskott Aldrich. So I'll speak a little bit about that.
I was a fellow.
At the beginning, the patients with Wiskott Aldrich were the ones that had most of these severe complications. So the severe infection and the severe autoimmunity. And then there was another disease, or what we thought was another disease, called X-linked thrombocytopenia, which was patients who also had just the low platelet part, but otherwise didn't have any of these complications. And it wasn't actually until we started learning about the genes that cause diseases that we figure out that both of these diseases were actually the same thing.
Yeah,
So both,
when the gene was discovered in 1994.
exactly. And so once we figure out that both of these things were the same thing, then the group of people that dealt with a lot of these patients came up with a scoring system to sort of describe very quickly how severe the patients were presenting. And so patients that have thrombocytopenia only were very low score patients, so low score 1, versus as you started having some of the other complications like infections, autoimmunity, and malignancy, that increased your points. And those were called classical Wiskott patients.
The other complication was eczema. Is eczema, so to have only thrombopenia or thrombopenia plus eczema only makes you in the what we so-called low risk, or stage 1 or 2, while all the other ones, infection, autoimmunity, or even vasculitis, make you at the very high risk. We agree on that, and that's what we say to the patients, and that's what we learn, and that's what we wanted to know if it's important or not.
Yeah. Now, I would say the caveat to that is, of course, that can change. So you can be a thrombocytopenia only patient now, and then that doesn't mean that you can't develop any of these other complications in the future. So I think it's descriptive for a good moment, but it doesn't really tell you what your long-term risk of all of these complications is.
And is there a link with the mutation, between the mutation, the type of mutation, and what we call the phenotype, which means severe disease or not severe disease?
Yes. So there are actually there's been very recent research looking into this, the different types of mutations and how to classify them. And so we really want to look at how the gene is affected, where it's affected, and how that then affects the business of the gene. So how is the protein expressed and how can this gene regulate our immune system and our hematologic system. And so that has really come to light in a recent paper from our European colleagues, and actually something that we decided to look into and apply it to a very large cohort of patients that we studied that underwent transplant over a long period of time.
So to clarify for the patients, it means that you can have a mutation of this gene to be affected, to have the disease, but the mutation of the gene can sometimes lead to the absence of protein, while in other circumstances, another mutation is going just to lead as a dysfunctional protein, correct?
Yeah.
And because of dysfunctional versus no protein at all, then it may be a severe phenotype if there is no protein at all, while it could be a less severe phenotype if there is some protein and some function. Do we agree on that?
Yeah.
Okay. So tell us now about your study. What were you looking for in this big cohort that we've built in PIDTC? What were your hypotheses? What were you doing this funny study? Explain us.
So first, a huge plug for PIDTC studies, because it makes things like this possible for such a rare disease. We were able to look at over 35 centers in the United States and Canada, and our total number ended up being 308 patients that were transplanted over almost 3 decades. So that gives us, for a rare disease, a really good number of patients to study and see how they respond to the treatment. So we specifically were looking at outcomes of stem cell transplantation for Wiskott Aldrich syndrome. And so basically we wanted to see, how do these patients do overall? How do they survive the transplant? And that's been reported in some previous studies that our group put out. We also really wanted to look at this study and say, how successful was the transplant? So on top of, did they survive, was the transplant successful? And were they able to keep those donor cells that can then function normally for the patient, so that they can have pretty normal platelet counts and resume normal activities? So that
What do you mean by successful? If I were a patient, what does it mean successful?
So your doctor, if they haven't already, will start talking to you about kind of how we can study donor cells after transplant, and we do that with something called chimerism. So the chimera is an interesting thing from history as well, but it basically tells us that within one human being, you can actually have DNA from the recipient, the patient, and the DNA from the stem cell donor. And those things can coexist. And we see this in non-malignant transplants that we do, not uncommonly. But the question is, how much of those donor cells do you need to maintain cure of your disease? And this is a very active question in our field for so many different diseases. So we wanted to look at that and see what patients with Wiskott Aldrich syndrome had a transplant where they could keep the donor cells, keep their platelet counts, and didn't need a second transplant, didn't need some sort of second intervention.
Just maybe to reassure the patients, there is not a mix of DNA, correct? The recipient has the hematopoietic cells, the cells in the blood come from the donor, but there is not in the same cell some DNA from there. It's not. We agree on that, just to reassure the patients.
Yeah, so I mean, basically, it's looking at some residual cells of the patient that stick around after the stem cell transplant, and this is something that is again not an unexpected thing that can happen in the blood and in the bone marrow, but it doesn't affect the genes of other things, like of tissues of skin, of things like that.
So it is related to the intensity of the engraftment. If the engraftment is full, then there will be a full chimerism, while if the engraftment is, let's say, 50%, then there will be a 50% chimerism. Yeah. Okay.
Correct. Yeah.
And tell me, as a non-transplanter, what kind of transplant strategies in general? So it seems like intuitive that you could really use very strong conditioning and get maybe complete engraftment, but maybe that would come at some cost. And it seems also intuitive that maybe if you were able to tolerate some donors or some recipient cells in there, you could maybe use a gentler conditioning strategy. So help me understand that. And what were people in your study using?
So I would say exactly to put it all together, when we're doing a stem cell transplant, what we'll use is some sort of chemotherapy to empty out the bone marrow of the patient. And then we want to replace that bone marrow with our donor's marrow, right? And that marrow is going to have those new cells, including the new white cells and the new platelets that are going to work okay, so that we can cure the main manifestations of the Wiskott Aldrich, right? Which are the low platelets and then this bad white cells that don't work very well. So you can play with the type of chemotherapy that you give the patients, exactly as you're mentioning. If you go with very high doses of chemotherapy, that gives you a higher chance of fully emptying out the marrow so that all the cells after are going to be from the donor, but that comes at the risk of more toxicity because you're using more doses of the chemotherapy. So because of that, there's been a lot of attempts to try to lower the amount of chemotherapy that we give. But that's exactly right. The less chemotherapy you give, the higher the chance that some of those cells from the patient might still be alive in the marrow. And that's where you can see that mixed chimera that Dr. Alexander was talking about. So really, one of our big questions was we wanted to see all of the chemotherapeutic regimens that were used and see, is there one that is associated with a higher chance of you having enough cells to fix both the platelets and the immune aspect of the disease without causing significant toxicity or a significant risk of you having to undergo a second procedure because you failed the first transplant because we didn't give you enough chemo.
So now we are excited. What were the data? What did you find?
Well, so when we looked at all of those patients, there were a lot of different chemotherapeutic regimens used through the 3 decades, as you may imagine, but we were able to bulk them up into groups. And so the vast majority of patients that were in the group used busulfan-based regimens. But even within the busulfan-based regimens, some of them were very high doses or combined with medications that can make it a little bit more toxic. And we call that the myeloablative busulfan group. And then we had a second group that had busulfan, but at lower doses or with medications where that combination is less toxic. And that was called the reduced intensity busulfan group. And then different from busulfan is another medication called melphalan that can also be the main part of a regimen. And so that was our third group, was a melphalan based, which is also considered reduced intensity because it's a lot less toxic than that myeloablative busulfan doses. So these were our big 3 groups. And so we compared myeloablative busulfan, reduced toxicity busulfan, and then reduced toxicity melphalan. And we looked at those patients and we were again looking to see survival, but not only survival, how many of them were able to be cured of all the manifestations, and also if there was a higher chance of them needing a second procedure.
So 3 groups, one big high busulfan, while lower busulfan, and one melphalan. There was supposed to be a big difference between the low busulfan and the melphalan. We didn't know where the melphalan would be actually. Correct?
Yeah, I think that so over time, as Dr. Davila was saying, these regimens have evolved. And also different centers kind of have different preferences sometimes on the agents that they use. So we did the best we could to put patients in these groups. And we wanted to see if there was, especially between the reduced intensity conditioning regimens, because we do appreciate the fact that with more intense chemo, there's also more risk of side effects. So we really wanted to say within those that are reduced, do we see a difference? And we did see, even with reduced intensity busulfan, even though it was reduced, it was still superior to the melphalan-based regimens.
What is the best
So
one?
it's kind of a game of trade-offs.
Yeah.
Yeah.
I mean, what's the verdict?
Who is the winner? Who does the best? The next transplanter, what should they use? Or tell us what you found.
I think that this is a very charged and challenging question. I think that I do want to say that, the cohort that we were studying was literally going back to 1990. So things have changed a lot, to the point where, just to put in perspective, when we were looking at, for example, some of the medicines used to prevent graft versus host disease, that approach even has changed substantially. So that affects a lot of things. If you get bad graft versus host disease, then you can have other complications and risk of death. So I think that that's super important. And one thing I just want to focus on is really, if we look more at the patients post the 1990s, the outcomes are really, really excellent overall. So I think that's the biggest thing I want to make sure people understand, is that there are really great outcomes for the modern era. And you know, it's hard. We're trying to look at these things as best as we can, but we did see some trends towards lower chimerism and lower platelet counts in patients who got melphalan-based reduced intensity conditioning regimens.
So to be sure I understand, when you give melphalan, you have less chimerism, meaning there is less cells from the donor, okay?
Yes,
And
or mixed. Yep.
this is associated with a correction of the thrombopenia that is not perfect, a kind of persistence of thrombopenia, correct?
Yes.
Okay.
Yes. That's what we saw. I mean, within the limitations of, you know, looking at this over many institutions in a lot of these were studied what we call retrospectively, meaning another plug for the PIDTC and other clinical research trials is that, you know, for people that enroll in what's considered more of a prospective study, where we collect data as we go, that'll gives us power to ask a lot more questions and get more follow-up and things like that. Because I think, you know, there are very, very important things that I know personally have happened to some babies who have been through myeloablative busulfan, including, you know, kidney failure and respiratory failure, and really, you know, threat on their lives. And thankfully, a lot of these babies have still survived, which is really awesome. But it's a lot to go through
So,
that, and there can be lasting effects of things like that as well.
so if I summarize what you say, busulfan is better than melphalan, but it doesn't need to be sky-high busulfan, because sky-high busulfan is more toxic. With a lower dose of busulfan, you can do as well without harming too much the patient. Am I right?
Yeah, and another thing I think, just to make sure, and then I want to hear Dr. Davila talk more about this too, is that, you know, again, things have evolved over time. So our ability to look at busulfan levels, we can actually measure now. So we give, you know, we initially, I mean, even early in the study, they were giving this chemotherapy orally, for example. Then it advanced to be given IV, which was improved. And then it advanced to saying, okay, each individual patient processes this medication differently. So let me study this patient. Let me give the chemo. Let me draw their blood, and then actually see how does their body clear this drug. And so the ability to do that is, again, a new, exciting thing to do. So looking and comparing that to potentially new agents that are coming out in the market could be very interesting to know.
Blachy?
I just wanted to add a little bit more about that busulfan part, because you hinted at it, Elie, and that is true. When we compared the myeloablative and the reduced toxicity busulfan, we did not see a difference in survival, which is good in the sense that we did not cause a lot of excess mortality when we were using the high doses. But we also didn't see a difference in how well the patients did post-transplant. That is, both groups had very similar recovery of their platelets and chimerism post-transplant. So exactly as you're saying, I think that means that you can get away with that lower dose of busulfan, which will decrease your risk of toxicity and not really decrease your chances of having good platelets and good immune function after. Now, when you're reducing the busulfan doses, what we talked about is that sometimes you can have a higher chance of that mixed chimerism that Jessie mentioned before. So another one of our big worries was, you know, if we see a bigger risk, if we see a bit more mixed chimerism after, does that mean that those patients might still be at higher risk of, you know, autoimmunity or any of these other complications that we're trying to cure from the Wiskott Aldrich? And thankfully, we did not see that either. So putting it all together, the reduced toxicity should hopefully decrease our chances of the toxic part of the regimen, but results in the same cure and does not seem to increase your risk of autoimmunity or other complications post-transplant.
So when we hear you, it may, from outside, maybe people who don't work in our field, you say, this is very technical, all those studies for just dose of what. Is it true that when you are speaking of a patient who want to transplant, you don't know which dose to take, and people are not fighting, but arguing each other, I should use this, you should use that. We don't know which conditioning regimen to give before your study?
Yeah, I think that is, again, a huge shout out to some of the things that we can do with the primary immune deficiency treatment consortium data, because these are very, very rare diseases. So even a big center that sees tons and tons and tons of patients with immunodeficiency, at best, you're going to see maybe 3-4 patients a year. So then it all becomes anecdotal, right? And I can chat with my colleague, who is an expert and who does things different than I do. And we really can't tell because we're comparing 3 people to 3 people. But when we have such a huge group of 300 plus patients, we can actually gather data and compare how they do. And also compare data from many, many centers so that we're not just talking about, oh, I did this versus you did this. It's really a collaborative of people, and we can compare apples to apples that way and get more information in terms of what's best for the patients.
That's really cool. And thank you both for sharing this research. Now, one thing I just had to ask you is what are some of the things you've learned along the journey here? You did a big study, bigger than we could have probably done without something like the PIDTC, getting all the patients together for us to analyze. What are some of the cool things you've learned along the way that are going to inform your practice, besides the obvious?
Cool or not cool? Maybe you learned a bad thing.
Maybe not cool. Yeah.
Together, having headaches, convincing people doing this or what. Tell us a bit of personal things during this study.
Oh my. So yeah, it's been very interesting to note, as you're saying, we don't have a ton of data for a lot of these rare diseases, right? But we've also been doing things the way we think they work for a long, long time. So I think gathering this data has been very interesting from that standpoint, because as we start asking questions, some people might be like, wait, why are you asking that question? I thought we all do this way and that's it. And so we were like, well, yes, but perhaps if we have the data to prove that that's the best way to do it, it would be better for everybody involved. So I think that was a very interesting discussion as part of this all came to be, is just becoming more sort of like getting to know more of our own biases in terms of how we think things should be done.
Interesting. Jessie, you have the same experience or others?
I mean, I always think it's very humbling to kind of have, it's always humbling to be with the patients and families, right? And just to try to help them go through this process, give them the best information that we have. And I think that it's also in a slightly different way, it's humbling to look at all this data that we have and then try to think of questions that we can answer for future, I think is something that I'm always very excited about. But I think another thing that struck me is just that, we were talking a little bit about the intensity versus if you do more intense, then the transplant will work. But we actually also found that that wasn't always the case. So we found some patients that even had fully myeloablative chemotherapy actually still needed to get a second transplant. And even patients who had a matched sibling transplant. So I think to me, it brings me back to, the challenge of this job that we do and the importance of all working together to figure out how to address especially the challenging cases where patients need a second transplant or need us to think more creatively about their treatment.
I think it's very important what you're saying. It's not because the study told us that statistically it's better to do this or to do that. For one given patient, we don't know before doing it. We are going to follow the stats, but maybe for this patient it was not a good call actually, and you know it later on. Did you have one of you have experiences with patients regarding this study, discussing of this study with patients, or did you have some personal input from the patients or their families?
I could say that I definitely had a family that I just, still connect with very, very well, who was really having a difficult time figuring out. We actually had a study that they could have joined, which was not myeloablative busulfan. But, I shared with them the data that we had at that time. That was definitely the most experience. And I think what we consider standard of care is like the myeloablative busulfan route. Um, and with a lot of informed consent and discussions, we did end up going forward with a myeloablative busulfan regimen. Happy to report that he survived and his disease was cured, but it was eventful. He didn't have respiratory or renal failure, but he did have a really significant pericardial effusion that needed to be drained a couple of times. So, it's a lot that these
Yeah.
families go through.
Yeah,
Yeah.
it's a lot. It's a lot. And at the PIDTC, we know that very well. We are very, I think we are advanced with our relation with the patient advocacy groups, and particularly the patient advocacy group for Wiskott Aldrich and the XLT. So I think it's very important to continue to work with them. It will be better for all of us. Any other personal comment regarding this study, Blachy or Jessie?
Say I had a similar, very interesting discussion with the family because I had a patient that had mostly the hematological manifestations, right? So mostly just low platelets, but thankfully hadn't dealt with a lot of the autoimmunity or infectious complications of the disease. And that was one of the questions that was brought up when we were chatting about things. It's like, well, you tell me that a lot of these patients are transplanted for immunodeficiency, but like, are you sure that if we do this transplant, the platelets are going to be okay post-transplant and these patients are going to do well? And so I think, we didn't touch in a lot of detail about this, but in this study, we did actually compare, the WAS score, or how patients were doing with just thrombocytopenia versus whatever complications and how they did. And patients with thrombocytopenia only did really, really well, as did patients with with the autoimmunity aspects of things. And so I think we now have the data to say that, yes, we are very good at curing the platelet-only manifestation of the disease with transplant. And that made I think a big difference in this conversation.
Yeah, you're right. It's very important data because not so many patients with just the thrombopenia have been transplanted. Now we have enough to say, look, we did it. Transplantation has been done for them also, and it worked actually. We knew that it could work. Logically, it should work, but thinking and demonstrating it's two big different things. So for the patients, it means a lot. So yes, thank you.
Can I
Yeah.
what you're saying, Elie, makes me want to just also say something that we found that when you asked me what was an impression. So when we actually looked at the patients that had the more severe mutations versus those had the less severe, what we found is that they did the same post-transplant. So I think biggest question everybody's going to ask, they both did the same. But they also looked the same when they came to transplant, which I think speaks to what Blachy was saying, is that this is a snapshot in time when we get this WAS score. And so what we saw is that by the time they actually came to transplant, even the patients with less severe mutations had a higher WAS score. And we also saw that they were older. So we think that means that people were waiting on these patients and just not doing transplant because they weren't that sick. And then by the time they came to transplant, they had more of these disease manifestations. So, I think speaking as an advocate for the patients would say we should intervene sooner because the outcomes can be better. And and a lot less heartache as you're going through these complications prior to
That's
transplant.
very important. That's very important. I do agree. Wow. That's cool.
Some good information.
Yeah.
Thank you so much to both of you.
Yes.
And Elie, too, who's an expert on this. Thank you guys for explaining this. I think this is a great example of a study that can be done using the collaborative centers working together to do research that's cutting edge on very rare diseases. That the PIDTC lets us do that is a great thing. But thank you both for sharing your research with us.
And guys, it was the first, and it went very well.
Yeah. Now, if you enjoyed this episode, please be sure to subscribe and share it with anyone who might benefit, patients, colleagues, or friends.
It's sure they enjoyed this episode. It was the first one, but it was amazing. And as always, you can learn more about the PIDTC, and if you need additional resources, please come and visit our website at pidtc.rarediseasesnetwork.org with a beautiful French accent.
And thank you for listening. We will see you next time.